Thank you, Dr. Yasser. Thank you, Professor Yasser Said, for this knowledgeable, elegant presentation, as usual. And thank you, Professor Alvaro. Now we will open the floor for the questions. We have questions here, but it's not directed. We'll start by Dr. Alvaro. What is the best? Yes, okay. Dr. Alvaro, what is the best non-invasive modality of ventilation to manage a baby with total lung collapse and right Yes, okay. We have left side collapse. Yes, this is a question. What is the best non-invasive modality for ventilation to manage baby with left side total lung collapse and right lung hyperinflated till bronchoscopic management? Will non-invasive high frequency is a good choice?
Okay, I guess if you have a baby with a total lung collapse unilateral, that baby may need to be intubated. It's going to be difficult to maintain that baby with non-invasive ventilation just if you have a total lung collapse on one side. It will depend on the blood gases, I guess. If either you are intubated or not, those cases are tough because, as you know, first of all, you need to know why. You have one lung that is completely collapsed and one is open. It could be secretions, could be a mass, could be something obstructing the airway on that side. In those cases, what I usually do is try to, if the baby tolerates that, is try to put the good side lung down, so the baby on the good side down, and try to keep the lung that is collapsed up. See if you can direct most of the pressure to that collapsed lung. See if you can re-expand that lung. High frequency nasal ventilation, I don't think it's a good option for that. As I said before, when you have a collapse, you need to use pressure. And I think there is no advantage of using high frequency nasal versus just regular CPAP. You need to use enough pressure on the CPAP to open up that lung. So I would not use nasal high frequency, try to reopen one lung, at least non-invasively. In that case, just PEEP alone, whatever PEEP you need to open up the lungs, keeping that side up and the other side down. And if you're intubated, I will use the same. I will use the right side down, the bad lung up, and you need to use PEEP, maybe a longer inspiratory time, to see if you can open up that lung invasively. So I don't know if I answered your question.
Okay. Thank you. For a high flow or high humidified nasal cannula, you said we don't like to recommend as a primary line for management for respiratory distress. Would you like to recommend in larger baby or term or late preterm babies, like with transient tachypnea of the newborn, because this baby usually is more resistant to the CPAP, and fixation usually difficult in them. Okay. As a primary?
I would personally not recommend using high flow nasal cannula as a primary mode. If you have a baby that has even transient tachypnea that you know is benign, and the baby needs standing pressure, you need to use the standing pressure properly, and that's nasal CPAP. Okay? The fact that the baby is going to like the high flow better is not up to the baby, it's up to us to give the best treatment for that particular baby. So it's not up to the nurses, it's not up to the baby, it's not up to the parents. It's up to what the best for that baby, for the lung, and that's nasal CPAP, it's not high flow.
Good. For case scenario number 1, would you recommend surfactant? You didn't mention to give surfactant for this baby if you have a heterogeneous lung disease. Would you like to use surfactant in the management?
For heterogeneous lung disease, homogeneous?
For the first.
Oh, for the first case.
Yeah, first case scenario.
Yeah, when you have homogeneous lung disease, those cases are easier, depends on what the cause is. You may have homogeneous lung disease because of diaphragmatic hernia. We're going to discuss that this afternoon, in which surfactant is not indicated. You may have non-homogeneous lung disease because of meconial aspiration. And in that case, if your oxygen requirement is quite high, yes, surfactant, it is indicated. Same with pneumonia. If you have non-homogeneous lung disease and you require high oxygen, surfactant is indicated. So it depends on the condition you're dealing with. But yes, if you're dealing with a low compliance and a high FiO2, surfactant in general is indicated.
Concerning the first case you presented, here the differential diagnosis is between meconium aspiration and pneumonia. Do you think, first question for this baby, do you think in such facing this unhomogeneous lung affection, would you use primary ventilation mode high frequency rather than conventional? Would it be a better option to use high frequency rather than conventional in such case? And second thing, you mentioned the increasing inspiratory time because of the time constant. That's true for meconium, but if this is pneumonia, are you going to increase the time constant or reduce it?
Okay. Personally, I would not use high frequency before conventional. That's me. There are people that are convinced that high frequency is better. I think if you know how to use conventional ventilation well enough, you can ventilate most babies with conventional alone. In general, babies like conventional ventilation better than high frequency. I only use high frequency when I'm failing conventional ventilation as a rescue mode. Again, there are centers that use high frequency as a primary mode. I wouldn't argue with that. There is no evidence to suggest that that's better than conventional. But whatever mode you use, as I said in my presentation, you have to use it properly. Okay? So only when you are using properly and you're failing, then you need to move to another mode of ventilation. The difference between meconial aspiration and pneumonia, they could be quite similar or quite different. Meconial aspiration is a label, but meconial aspiration can give you significant air trapping as a primary pathophysiological mode, or it can give you primary atelectasis, or it can give you primary pulmonary hypertension. So meconial aspiration is one, but you need to know exactly what's the main pathophysiology for that meconial aspiration. So you don't ventilate all meconial aspiration the same way. You need to decide what's the main pathophysiology. If it's atelectasis, use one mode. If it's pulmonary hypertension, you use different mode. And if it's air trapping, you use a completely different mode. So, as I said, it's not so much the name of the diagnosis, it's the type of pathophysiology. Pneumonia is the same. With pneumonia, you can have significant atelectasis, you can have significant pulmonary hypertension, or you can have air trapping. Okay? So again, depends on the pathophysiology, not so much the name of the condition you're dealing with. I don't know if you understand. In terms of the time constant, in general, babies with non-homogeneous lung disease, regardless of if it's meconial aspiration, diaphragmatic hernia, or pneumonia, time constant means that you need longer inspiratory time to reach the alveoli, and you need longer expiratory time to get rid of all that air. So it's tricky. I'm not saying it's easy, because you need longer inspiratory time, but at the same time, you need longer expiratory time. You need a total time for each breath that is longer than normal. And it's hard when a baby is breathing spontaneously and is breathing 100 per minute. So in that case, you need to know, well, why is my baby breathing 100 per minute? Most of the time it's for two reasons. One is because the CO2 is too high. You are not ventilating the baby. You are not providing good ventilation. That's why the baby is breathing 100. So you need to take control of the ventilation. Or the baby is hypoxic. Then you need to know why the baby is hypoxic and control that. in some cases, you need to sedate the baby and control the baby. You may need to use a higher tidal volume to bring the CO2 down. You may need longer inspiratory time to achieve better minute ventilation and bring the CO2 down. And see if it's pulmonary hypertension, you need to deal with the vasculature also. So I can't give you one recipe for everything. So again, you have to look at the main pathophysiology you're dealing with and adjust your settings and your treatment according to that.
The example you gave was the baby having a hyperinflated lung and CO2 retention, and you proposed to sedate, and the patient was put on assisted control as volume guarantee. Is there any option of modifying your trigger so that you will respond to
Yes.
lower rate?
Yes, you need to use a higher trigger.
Instead of sedation? So
Again, yeah, the trigger should be slightly higher than we use a preterm infant. And a preterm infant, the smaller the baby, the lower the trigger. So in a bigger baby, you need to use a higher trigger to avoid auto-triggering. But the question with sedation or not, it depends if you can control. If you can control the CO2 and the hypoxemia with your ventilator and your management, you may not need to sedate the baby much. You will see that the baby will slow down on its own. As soon as you bring the CO2 down and you improve oxygenation, the baby will slow down. There is a reason why the baby is breathing fast. He needs to breathe fast to bring the CO2 down. So if you can do that with the ventilator, the baby will slow down on its own. But sometimes you need to, sometimes agitation, just because the baby doesn't like to be intubated, can cause high respiratory rate. So that's the type of sedation that you need to use to bring the irritability down and see if you can control ventilation better. I wouldn't say paralyzing the baby, I said just use proper sedation. Sometimes means just, if the baby is extubated, just chlorohydrate. Doesn't need to be narcotics. Okay? I hate narcotics, by the way. But if the baby is intubated, sometimes you use to use a little bit of narcotics. Until you control the ventilation, and then you can slow down your sedation.
Patient, you said that to decrease the hyperinflated patient, you decrease the inspiratory time because he's hyperinflated. But I think that CO2 is much higher. Can we use inspiratory time more in much more longer time?
Yeah. So when you have just air trapping, most of the time is because in cases of meconial aspiration, and in your case, your airway resistance, the upper airway resistance is high. So, you need to prolong your expiratory time. Now, if you don't have significant issues with oxygenation, sometimes you can shorten your inspiratory time to allow you to have more expiratory time. But you have to be careful that you don't go too short your inspiratory time, because you may get into trouble with not enough inspiratory time. These babies are the trickiest one. I'm not saying that it's easy. I'm not saying, oh yeah, they do this and everything will be fine. These are tricky situations. But you need to be sure that you have enough expiratory time to prevent air trapping. And you need to look at your flow waveform. And always be sure that your expiratory flow goes back to baseline. Okay? Otherwise, you are not going to get into, you're going to do this vicious cycle that you're not going to get over that. Okay? Sometimes it means that you may need to switch to high frequency, although with air trapping, I would say conventional ventilation is safer than high frequency. Definitely, I will not use the oscillator when you have trapping. That to me is the worst mode of ventilation when you have a trapping is the oscillator, because the oscillator, it sucks the air out of the lungs, and that predisposes to air trapping by itself. Even if you don't have problem with air trapping, the oscillator, if you don't use it properly, it will get you into that trouble. So either I will switch to conventional or I'll use a jet. Sometimes the air trapping occurs because your endotracheal tube is too small. And so that will increase also your airway resistance and will cause inadvertent PEEP. So then you need to change the tube and put a bigger tube. So you have to see if you can control the air trapping with your settings. You may have to look outside the box, and maybe it's a tube that is too small, or maybe secretions. So,
Professor Yasser, is the oxygen toxicity is related to oxygen delivered FI2 or the set by the pulse oximeter? The oxygen toxicity is related to the what oxygen you delivered, FI2, or the set by pulse oximeter?
Yeah, that's a very good question. As I mentioned during the presentation, that pulse oximetry just give you one part of the equation, which is oxygen saturation by all the hemoglobin. So for example, you may have someone on 50% or 60% FiO2, and the oxygen saturation might be close to 100%. But when you check the arterial blood gases, you will get the PO2 very high. It might be 200 or even more, because you have room up to the total pressure, barometric pressure, which is 713 if you exclude the water vapor when you give too much oxygen. So the pulse oximetry is very limited. There is another limitation of the pulse oximetry, which might make it unreliable when you have infant really sick with the poor perfusion. The pulse oximetry is perfusion dependent, and you need to check when you rely on the number, the perfusion index. So when you have the pulse oximetry, any kind of pulse oximetry, either Philips or Massimo, you have another number which is close to it, which is the PI. You need to look at that number. This PI, if it is less than 0.4, it means that whatever number you get is not real number. It's not reliable. Yeah, because the saturation needs a good perfusion. A perfusion is acceptable as a PI perfusion index between 0.4 to 2.8 or close to 3 to make it easy and simple. So that's why the oxygen saturation is very helpful and very reliable. When you have a specific physiologic target saturation, you need to maintain that, but it's not the best way to evaluate hyperoxia or increased oxygen delivery. Oxygen delivery, it is one of the three parameters. Oxygen delivery, as I mentioned, it is oxygen saturation and the hemoglobin content plus the blood flow. So anyone might be high or low, it might affect oxygen delivery. It is very easy to calculate the number. Again, we teach our fellows that you need to do that at the bedside, not just to look at the number. You need to get the hemoglobin that was done recently for the same patient, get the blood flow measured by cardiac output at the last echo done, and then use the pulse oximetry or oxygen saturation at the same time of assessment, and you will get the oxygen delivery, as I mentioned, 20 to 40. When you have too much oxygen delivery, that's more reliable than just the pulse oximetry. Again, using near-field spectroscopy now as a continuous monitoring, because to calculate oxygen delivery, you need to do an echo, and the echo is just longitudinal assessment. You do it now, 2 hours later, the infant might be totally different. You need the gold standard for any monitoring, for any physiologic monitoring, is a continuous way. You look at like a trend over time. So the near-field spectroscopy is very helpful now to know about the blood flow and the fluctuation. If the fluctuation of any vital sign, either the blood pressure or heart rate or the oxygen saturation within the autoregulation threshold or exceeding or below. So if it is within the autoregulation threshold, we don't have to do anything. Just watch. You don't have to start medication for blood pressure, or you don't have to give too much oxygen. You just stay tight. If I mean stay as is. If there is exceeding or outside the autoregulation, then you have to intervene. Also intervene physiologic, not just empiric, to give the same for everyone, like too much oxygen and see the difference. You need to, when you give intervention, it should be explained with the underlying pathophysiologic mechanism.
When you stop using caffeine in preterm babies?
Yeah, the most expert caffeine physician in Canada is included in the caffeine trial.
So what's your question?
You are using caffeine for how, when to stop it? Post-gestational age.
How much time do you have? It's a loaded question. Yeah. Definitely for babies under 32 weeks, I think caffeine is indicated in almost 100% of the babies. Over 32 weeks, I will wait until the baby shows some apneas before we start caffeine. Now, when you stop caffeine, it depends. If a baby has bronchopulmonary dysplasia or chronic lung disease and is CPAP dependent, I will not recommend stopping the caffeine before you stop the CPAP. And many of those babies will actually require caffeine for a long time, even after discharge. We usually discharge at least an average of 3, 4, or 5 babies a year from our unit on caffeine. Okay? and they require caffeine sometimes for 6 to 8 weeks after discharge. However, if a baby has good lungs, as soon as the baby starts having events, significant events, you can stop the caffeine. You don't need to give those caffeine for a long time. But one thing that you always need to do when you stop the caffeine is not just looking at the apnea record that the nurses will present to you, is look at the histogram, oxygen saturation histogram, because it's much more objective and it will give you much more detail. So you can need to compare before and after you stop the caffeine. And remember, caffeine has a half-life that is 5 to 7 days. So you can't expect to see significant changes after 24 hours. You need to follow the histogram for at least 5 to 7 days after you stop the caffeine to be sure that you don't need to restart that.
Yeah, I have a question. But to all of you. So how many of you just raise your hand using oxygen histograms daily in the unit? Raise your hand. So we have Dr. Asma, but you are in Saudi Arabia. Talking about here.
Okay. Next year when we come back, it has to be 100%. Okay?
So if you get out of this conference and started to use the oxygen histograms, that's enough, I think, success from our lectures today. That's very helpful, at least to monitor continuously on daily basis to know exactly the impact of if you give too much oxygen or you give less oxygen. So you follow the trend with the exact time within the with each bar of oxygen saturation interval.
I think we must end this session, and we are going to do the second session because the time is out for 15 minutes. Thank you very much, and the professors, and we'll meet you again.
We are happy to answer the rest of the question during the break.